Again, welcome to all that have joined us. We appreciate you taking the time, especially here at the noon hour, to dive in and look at a little bit of what's going on with rural healthcare in Texas. And we're extremely thankful and grateful to have Nora Belcher with the Texas eHealth Alliance to join us. We also have Jennifer Harris on today, the Executive Director for the Connected Texas Program. Jennifer, I'll turn it over to you for just a moment.
Thanks, Wes. Hello, everyone. I am in Cleveland, Ohio today. I've been attending Pew's Broadband Access Summit here in Cleveland. The weather is amazing, let me tell you. Way, way, way colder than it is in Texas right now. So I'm a little disappointed to come back tonight, but not really. I'll be glad to be back in Texas. But lots of good information here. Lots of folks from Texas made the trip. So hopefully we can share what we learned with y'all soon. But today we're going to focus on telehealth. And I'm so excited that Nora is able to join us. I've known Nora for, well, I don't know how many years now, more years than I can count. She spent time at HHSC. She's worked in the governor's office, and currently she is the CEO of the Texas eHealth Alliance, where she will have been for 13 years in September. So that's a great bio for her, and I'll turn it over to her to get started.
Thank you so much, Jennifer, and thank you to Connected Nation for having me. I am coming to everybody from Austin, Texas, where it is hot, because it seems like it's always hot here. In fact, our air conditioning is having issues, so if you hear thumping noises, that's a good thing, because that's the air conditioner repairman working above my head to try to keep all of us alive as it gets really hot here in Austin. I really appreciate the opportunity to spend some time talking to you today about where telemedicine sits in the rural health space. I suspect that a lot of you are probably familiar with the term telemedicine. Maybe you even used it during the pandemic. I want to spend some time, though, talking a little bit about how this matters for rural communities, how it ties to broadband, maybe challenge you a little bit in the way you might be thinking about the utility of these things and what they might mean for your community. Because even though we all saw this huge explosion in telemedicine during the pandemic, I think sometimes people are still struggling a little bit to connect to what does that mean to them and where do they take it? So that is my goal for the next few minutes, is to talk about that. I really appreciated Jennifer's introduction. We have known each other a long time, and I really enjoyed getting to work with her on House Bill 5, the Texas broadband bill, this last cycle. We hung out in committee hearings and got to partner on a bunch of stuff, and the interaction between the broadband community and the telemedicine community is a really important kind of nexus. I have been at this for a long time. The one thing I wanted to add to my bio is that I'm actually a computer programmer with a political science degree. So I love the intersection of healthcare and technology. It's the space where I'm the happiest in terms of doing public policy work. And I did win some programming trophies in the 1980s. I can make a ball bounce around on a screen really, really well. Obviously, we've come a long way since then. If you're hearing me for the first time today, you may not be familiar with my association. So I want to spend just a minute talking about that. Our mission is to be the state's leading advocate from local communities to the national level for the use of health information technology to improve the healthcare system for patients. Everything that we do brings the patient to the center and tries to figure out how to use technology to solve problems to improve their healthcare. We are a 501c6 nonprofit, so a trade association. As such, I cannot recommend or endorse specific products or specific companies. I'm here to be an ambassador for the industry, to work on policy, those sorts of things. But because I represent competitors, I am prohibited from editorializing on specific products and companies. Here's the outline of my presentation. I think it's always important to start with understanding your topic and definitions. And so we're going to start with that, because you really do need to get yourself grounded in what exactly are we talking about. I'm going to spend a couple of minutes recapping some of the legislative activity from the last 3 legislative cycles. Believe it or not, Texas was leading in this space way before the pandemic. That may not be a surprise to some of you. That might be news to some of you. I'm going to talk briefly about some case studies because I think implementation is really important for folks to understand exactly how this plays out in the field. And then some editorial thoughts from me to share, advice for communities, some closing thoughts. And then I do believe that we have some time at the end for Q&A. And I believe Wes has put in the chat that he wants to see folks use the Q&A function to ask questions. So with that, let's get into the meat of it. First of all, we really need to talk about definitions. Every state defines telemedicine and telehealth differently, as does the federal government. So it can be very confusing as to why are there two terms? What are the distinctions? What are the definitions? Why does this matter? I'm not going to read the definition word for word to you. However, there's an easy way to remember the difference in what Texas means when we say telemedicine versus telehealth, and that is prescribing. Texas law makes a telemedicine medical service, which is shorthanded to telemedicine, to only be things that can be done by someone who's licensed to write a prescription. So those are physicians and then advanced nurse practitioners and physician assistants working under delegation and supervision. And then everything else is considered telehealth. And that can be anything from nutrition counseling, nursing services, mental health counseling, all sorts of things. Prescribing is an important component of this discussion because the ability to prescribe varies from state to state. Who can prescribe varies from state to state, and prescribing brings in a whole additional set of relationships, including with pharmacists, that are important for us to acknowledge. So the very short way to remember the Texas definitions is when we say telemedicine, we're really talking about people who can prescribe. They may not be prescribing in that particular encounter, but that's a medical service. The broader universe is a health service. And then we also have remote patient monitoring, which is a one-way transaction. So this might be a Bluetooth blood pressure cuff or a Bluetooth scale that's sent home with the patient after a hospital discharge to track their information, report it back to their doctor, and the doctor can look at it and see if action needs to be taken. I'm going to dig into that a little bit more further down the presentation, but I really wanted to start with definition because it's important to know what these things mean. I will also tell you that telemedicine and telehealth are frequently used interchangeably. Don't be surprised if you see that. Just understand that when it comes to what Texans can and can't do within these services, we're going to fall back kind of on these distinctions, and that distinction really does revolve around prescribing. I also, though, wanted to take a minute to use this really great slide from the American Hospital Association to talk about telemedicine and telehealth. And the reason that I think this slide is important is I think a lot of folks at this point in the pandemic think about telemedicine as a direct-to-consumer service. So you're at home and you need an antibiotic for a sinus infection, and you're going to get online through your phone or through your PC and use a telemedicine service. Maybe it's your doctor's office, maybe it's your doctor, maybe it's a doctor you've never met before to help you get relief for your medical condition. That is the most frequently thought of mode of telemedicine and telehealth. When I talk to people that aren't in the industry, that's what they think of first. But the truth of the matter is telemedicine, telehealth has an extraordinary depth and breadth of programs and platforms that are used to do all sorts of things. So when we talk about that, we frequently talk about what we call modalities. So that's on one side of the screen. Real-time interactions, which is what we're doing right now. What we call store and forward, which is the equivalent of watching this webinar, but not in real time. You're recording information. It's being reviewed later. And then, like I mentioned on the previous slide, remote patient monitoring. So live interactive is important, and for some things it's essential. For other things, you can not be in real time, and then sometimes it's just a one-way transmission of information. All of these things fall within the telehealth sphere. But it's also important to know that hospitals are doing an enormous amount of telehealth that is not direct to consumer. It's sort of integrated into the hospital's service array. And I wanted to talk about that for just a minute because I think that these are really important areas where there's a lot of growth. Telestroke care, radiology, not uncommon for that to be outsourced. Using telemedicine in ICU settings. I'm going to talk about that some more when we get to case studies. Telemental health, the #1 bill use case for telemedicine in the country is mental health care. Pathology, cyber surgery, remote supervision of pharmacy techs is something that's been implemented in Texas and many other states. and then of course consultations. So before I move into the next phase, I just want to make sure that I set the stage here appropriately. It's really important to think of telemedicine and telehealth as a way that we deliver an existing service. And we're starting to evolve some new services, but it's not a service in and of itself. You still have to be delivering some sort of clinical care, if you're just using the technology to do so, which is part of what makes the broadband conversation so incredibly important. So what has the legislature done? I've been working on telemedicine since 1995, when it was really in its infancy. And I had a revelation a few years ago that there are really three components that have to be met for there to be an ecosystem where telemedicine really flourishes: regulation, reimbursement, and rhetoric. And so the legislature for the last 3 cycles has made a lot of strides. Believe it or not, prior to 2017, we were probably in the bottom 5 to 10 states in most people's minds in terms of what we allowed for telemedicine and telehealth. In 2017, however, the legislature took action and passed Senate Bill 1107, which allowed direct-to-consumer telemedicine. You could already do this for mental health services, but we did not allow somebody to establish a treatment relationship from their home with a doctor they've never met, that doesn't know their regular doctor, before 2017. This turned out to be very timely because the bill became effective at the end of the legislative session. We were able to use telemedicine to help a lot of the evacuees during Hurricane Harvey. We wouldn't have been able to do that had this bill not passed. So that was the first piece. You have to have sort of a fair and open regulatory structure. The second piece is reimbursement. We have had for a really long time language in our insurance code for insurers that are regulated by the state saying everything is the same, and the only difference is it was a virtual service. We expect health plans to cover the service, but it's done via telemedicine or telehealth. And in 2019, Senate Bill 670 expanded that to our Medicaid MCOs. Texas Medicaid is 95% managed care. So it's run by health plans on behalf of the state. So it was really important for us to make the statement that now that we're allowed to do this under the medical board rules, now that we're doing this in a way that meets what's called the standard of care, we also expect for those things to be covered services. This gets tricky when you start to talk about private insurance not regulated by the state. Those plans play by a different set of rules, but the legislature has over the years taken a good hard look at commercial insurance that the Texas Department of Insurance regulates, and they've moved those policies forward. And then the third piece, sort of the rhetoric. And what I mean by rhetoric is you really want to have an atmosphere, not just regulation, not just reimbursement, but a commitment from your state to commit to these services and make sure that they are usable, accessible, paid for, regulated appropriately, all those things. So in 2021, we passed House Bill 4, which was a complement to House Bill 5, the broadband bill, to make all of the flexibilities from COVID-19 permanent in our public programs. So Texas Medicaid, because of previous legislation, had a lot of flexibility already to do this. But if you remember those really, really intense days at the beginning of the pandemic in 2020, you had to have a doctor's order to get a COVID test. And most physicians in Texas didn't have video capability. So we had to turn all that on, turn some of it on over the phone, turn it on during video. And then we discovered there were a whole host of other services that it felt very appropriate for telemedicine to be used to meet. When the legislature came back in 2021, which was sort of a strange legislative session between COVID and Winter Storm Uri, the Speaker of the House, Speaker Dave Phelan, making those COVID flexibilities permanent one of his priority bills, and that's how we ended up being House Bill 4. And I do want to report that, it's easy to be cynical about politics these days. Everybody's under a lot of strain. House Bill 4 passed with no opposition in the House, the Senate, or committee. It was a real bipartisan effort to expand permanently the use of these services for our Medicaid and children's health insurance populations. And I thought that was a really, really wonderful statement on behalf of the legislature. So once you line these three things up, regulation, reimbursement, and rhetoric, and you sort of set the stage for telemedicine, now what do? I can remember being at a rural hospital meeting in Texas in probably the fall of 2017. And I asked the audience, I said, how many of you are doing telemedicine now at your facilities? Some hands went up. I said, okay, how many of you feel pressure to do telemedicine? Like it's something that you should be doing. Every single hand in the room went up. And I said, okay, how many of you know what business problems telemedicine can solve for you within your facility? What functional problems, what business problems, what clinical problems? And a lot of the hands went down. So over the last few years, we've really been working to socialize the idea of telemedicine is a tool that can be used to solve problems. And what I'm going to do next is walk through a couple of case study examples of how the state of Texas has chosen through program and legislature to apply this to the benefit of hospitals and communities, because I think making it tangible makes a really big difference. I can talk about rhetoric all I want, but people want to see, how does this actually work? So the first case study I'm going to use is the hospital in Van Horn, Texas. If anybody affiliated with Van Horn is on this call, I'm incredibly proud of this hospital and this community. This is a very small critical access hospital. We did this, by the way, before Jeff Bezos and Amazon decided to pick it for a site that was really struggling with meeting the state's required trauma staffing levels. So in 2018, they added a telemedicine component to the emergency room. So what this is literally a button, drops some screens, drops microphones, and there is a fully staffed group of people, physicians, nurses, other folks on the other end of the video transaction to provide backup for the staff on the ground at the hospital, because that might be a physician assistant or an advanced nurse practitioner. This allowed them to still meet the staffing requirements for the trauma system. And the reason that's important is because we give our trauma system hospitals additional state funding. So they were really facing a loss of funding from dropping out of the trauma system, on top of struggling with really wanting to treat the folks on that stretch of I-10 that is so isolated that might be coming through their emergency room. During the 2019 legislative session, I had the privilege of sitting at a testimony table with the medical director from the hospital, who basically said, thanks to adding this telemedicine component, we can evaluate, stabilize, treat, and transfer somebody who's come into our emergency room before, and this is a quote, I can get my pants on and get to the hospital if he's not already there. This is incredibly important. If this hospital were to have closed, there would not be care on either side of that community for quite a long stretch. It also has allowed them to keep patients in the hospital by bringing additional resources in virtually to treat the patients, rather than having to put all of them onto an air ambulance, for an example, and send them to a bigger facility. We were really pleased to see how successful this has been. It's my understanding that a number of hospitals adopted this under House Bill 871, which passed that session, that allows hospitals and counties under 30,000 people to use this same model. This is a really, really important model for folks to think about, because with these small hospitals, they're not just acute care. They're just not just hospital care. They sort of have to meet a lot of the community needs in partnership with whatever physicians or other practitioners might be in their community. Using virtual care lets them not just stabilize and treat faster in an emergency setting, but also allows them to bring in services that they may not be able to physically have present in that facility. So it's really important to think about hospitals as a place that use telemedicine and telehealth, not just direct patient access like on the internet, or like you might see people advertising on TV. This is a different kind of model. It's been very successful. We're very, very pleased with the results. And I know that the hospitals that are using these sorts of systems are finding them to be financially positive, a good investment, and better for both the patients and the staff of the facility. So this is one of my favorite case studies, and I'm just really, really proud of that community for rallying around its hospital and finding a way to stay present for whoever might be in need in that very desolate stretch of land that now has rockets flying from there. Kind of an amazing story if you think about it. The second case study I want to talk about is also hospital-based, but in a different direction, and that's rural pediatrics. So we have been giving grants through the Texas Health and Human Services Commission to rural hospitals to expand telehealth services for children. This is intended to support pediatric specialists and subspecialists. This is another really important case scenario, sort of the opposite side of the Van Horn example. If you think about a family that has a newborn, perhaps, that has specialist needs, but they're born in the local hospital, frequently the family has to choose between If the child has to be transferred to a bigger city, do they go with their child or do they stay in their community where their employment might be? That's really not a societally healthy dilemma to ask parents to have to make that choice. Sometimes it's necessary. Sometimes the baby is just so sick, they've got to go to the specialty hospital. However, we have found that you can use telemedicine and telehealth to bring in specialty care through relationships with children's hospitals to keep those children in their local hospital, which keeps their families in the local community, keeps the dollars local, it keeps the jobs local, it keeps the care local. This is a model that started in Arkansas and has expanded to other states. And we were really delighted to see Granbury, Corsicana, Brownfield, and Mount Pleasant all receive grants to do telehealth expansions under this program. Right now, this is going to impact more than 25 counties. We'll see over time if we're able to continue to add grant funding to this. We actually stood the program up in 2017 with legislation to kind of administer, and it's taken some time, frankly, to figure out exactly how it might work, but the results are tremendous. I mean, think about being a parent with a baby in a neonatal intensive care unit. You may have had this experience yourself or in your family. You're already stressed out. And then the thought of a transfer, and then do you go or do you stay, and how's that going to work? That's really stressful. So if we can at least keep some of these children in their home facility, keep their families in their home, that's sort of a win-win for everybody, while we leverage the pediatric expertise at our children's hospitals to keep those babies healthy and thriving. This is a wonderful case study. I'm really proud of these communities for stepping up. I'm really excited over the next few years to sort of see data, kind of see and quantify the results, which will be part of the evaluation. There will be a report published on this later this year, and there's reports from previous cycles online. Happy to connect anybody to that information that might want it. Again, this has nothing to do with being an individual that sits and goes online to chat with a doctor. That's a great model. It's got utility. It's important. But when you think about rural healthcare, the challenges we have in rural healthcare are not going to be easily solved by people being able to get online and talk to a doctor that way. The models have to think differently about what are the challenges and then bring the technology in to address those challenges. So the Van Horn example, this rural pediatric example, I think are outstanding examples of how telemedicine implementation can work in a way that goes back to my rhetorical question to the rural hospitals. What problem are you using telemedicine to solve? If you start there, then a lot of these conversations become easier. What we don't want is people making big investments in broadband and equipment and other things without thinking about what application it's going to have for their facility, for their hospital, and for their community. In fact, that sort of takes me to my advice for communities. So I can't see you as an audience, so hopefully some of you recognize these America Online CD-ROMs in the 90s. AOL emailed everybody in America, mailed everybody in America these CD-ROMs, and my grandmother thought it was a coaster. She put her iced tea on it because she didn't have a computer. But for a lot of people, this was their first experience with the internet. And one of the things that we now know is that the role of the patient in terms of their expectations for virtual care was permanently changed by COVID-19. The data tells us that as many as half of Americans had a telemedicine encounter over the last 2 years, when we were running maybe 10 to 15% prior to COVID-19. And the feedback that I get from advocates, from stakeholders, is that they understand there'll be times they still need to go to the doctor, but maybe not every single time. And they want to see this access kept in place. We also are seeing that our providers who've adopted it are looking like they're going to keep it. There was a survey done by the Texas Medical Association maybe 2 years ago that said that 80% of Texas physicians were doing telemedicine, plan to do telemedicine, have it in their service offerings. So if you think about how long it can take to go to the doctor, you have to leave work, you have to drive across town, or if you're in a rural community, you might have to drive a really long way, sit in a waiting room, have your consultation, get back in the car, drive back to where you went. The tolerance for that has changed kind of among the public. Now, that does not mean everything can be done this way. There's certain pediatric things that must be done in person. I had an OBGYN come up to me recently at a conference and said, I'm not comfortable moving my practice this way outside of maybe consultations that are just conversations. I said, I agree with you. You still have to meet the standard for what's expected, but please understand we've always in medicine sort of had the patient go to the medicine, and that's been turned on its head. So what does that really look like? First of all, let's see here. It's important to keep in mind, and I've been saying this sort of along the presentation, telemedicine, telehealth are tools. They're only as good as their implementation. They're implemented well, they can help keep patients and reimbursements local. So keep in mind when people start talking in your community about telemedicine and what could it be, there are all these other models besides minor primary care. It's very important to keep in mind. But the second thing that I think is maybe more important, and in the prep for this, talking to Wes and Jennifer, this was a point that I think we all thought was critical, is you do have to have infrastructure, and you do have to have ways to track the needs of the providers and the patients in your community. But not every telemedicine implementation needs the same level of infrastructure for things like broadband. For example, a lot of mental health services can be done legally over the phone and can be reimbursed by providers over the phone. It's not my favorite necessarily, because I do think there's something to be said for being able to see someone's facial expressions. However, we do know we have a digital divide, and we do know we have broadband deserts, and we do know we have places that don't have the infrastructure to do a full video call right now. So when you think about how you might bring this into your communities, be mindful that some of these services, like mental health services and other forms of counseling, don't necessarily require a full-on video call to be implemented. And with mental health services being more important than ever, I would say, keep that use case in mind, that you don't necessarily have to do a huge build out if mental health services are the need. The biggest challenge with mental health services is that we just don't have enough providers. So telemedicine and telehealth doesn't magically create providers, no matter what somebody tells you, but what it does do is it makes the access easier. The more important thing, though, I think, is for communities to be opportunistic in terms of how they share resources. One of the things that I have seen over and over again as I talk to rural communities is we've got a T1 line for the hospital, we've got a T1 line for the library, we've got a T1 line to the school, and some of it is dark and not all of it is used. We have this really bad habit of funding things in silos. And the more that we can break those silos down so those installations can be multi-purpose to meet the needs of the community, that's efficient. That means we're being better stewards of the funding, but and it also means that you've got connections between those places. 15 years ago, it was really hard to have a school-based health clinic. We have school-based health clinics now all over the state of Texas that are using telemedicine and telehealth to help care for kids in schools. That's a wonderful example of how you just kind of shove those silos down just a little bit, create collaboration. You can really do some good things. So I understand completely that if you apply for a grant, sometimes there's strings on that money, but I'm hopeful now that we have a state broadband plan that we can start tearing some of those silos down and get more for our money with the implementations that we have funded. So be mindful of who paid for the line and what it can be used for, but also don't be afraid to challenge and ask if that line can be used in multi-purpose ways. I've seen some situations where the answer has been surprisingly positive. And then finally, just to close, and then I'm happy to go to Q&A. The future is not going to be completely virtual, and anyone who tells you that is selling you something, and you should ignore them completely. The future is really going to be a combination of in-person and virtual care. Virtual care can increase access to needed services, mental health care, specialty care, but it's not a magic solution. It doesn't create something out of nothing. I think another important dynamic for everyone to think about is the home as a site of service. This was starting to trend before COVID, and now it's really going to be important. The baby boomers, I love you all very much as a Generation X person, are just starting to get into their high utilization years. And I suspect they're going to think very differently about how they're going to want to consume healthcare as they age. They're going to want to age in place. They're going to want to age well. They're going to want to age at home if they can. Telemedicine and telehealth, again, provide a way to bridge to the provider from the patient without having to have them go in physically every single time. And in some cases can even be a supplementary tool that keeps somebody out of institutional care. And then maybe most importantly, what we know from the studies we've done with Medicaid is that virtual care can get to somebody sooner. If it's easier to get to the care, if it's not a 3-hour hassle, we might actually be able to diagnose them earlier and get them into treatment earlier. One of the biggest costs to the healthcare system is avoided care. Somebody gets sick, they can't get to the doctor, they can't get to the doctor, they don't get to the doctor. And by the time they finally get to the doctor, it's in the emergency room or another high cost setting. This accessibility that virtual care brings can really be a savings to the system. Yes, it might mean more office visits, but it also means we can get people into care earlier. Texas Medicaid has actually studied this, and in comparing cohorts that got telemedicine with cohorts that didn't, cohorts that got telemedicine had less emergency room use and less acute hospitalization use. And those are good things. Those are things in the system that we want to be driving towards, because those are costs that get shared by everybody. Not to mention, you can get a better outcome for the patient if you get to them earlier. So these are things to think about. Your community has people in it that have probably done telemedicine. They may want to have services at home. You may have a rural hospital that is evaluating how it can be of more service to its community in a broader sense. It's an important conversation. You might be working on infrastructure the way Connected Nation does. It's important to have the infrastructure in place. It's important for us to close the digital divide, but there's also not a one size fits all when it comes to infrastructure. Some of these services are more accessible a little bit more easily and don't eat up quite as much bandwidth. So you've got a lot of variation in the way you can solve your problems. And that's the last thing I'm going to say. I'm going to put my contact information. Telemedicine and telehealth is a great solution, but you've got to spend a little bit of time defining your problem, thinking about what problem you want to solve. Is it mental health care? Is it specialty care? Is it supporting your hospital? Is it helping people age in place at home? Is it addressing mental health care shortages? Because we have, as you all know, massive shortages of people who can provide those services. Once you frame the question, telemedicine is a great tool to use to have the answers, but always begin with that end in mind. And I think when communities do that, they have better results from evaluating how they might be able to use those tools. So with that, Wes, I think I will stop the deck, and through the Q&A or however you want to manage it, I'm happy to take questions.
Yeah, so I'm going to encourage all of our participants to, anybody that's got any questions, certainly please send those in, and that can be through the Q&A or the chat, either one, that's fine, or raise your hand. And I'm trying to keep an eye on our participants and whatnot. But Nora, thanks for really, it's a great way. It's set, like you said, you set the stage. Here's what's going on, and really here, those two examples are so meaningful because it does help us get so much better understanding of how these implementations are impacting communities. One of the questions that just came in is from Catherine Krantz, who is one of our BSMs here at Connected Nation Texas. And the comment was, what ideas do you have for communities without a hospital at all? Sure. How can this impact it?
Sure. Catherine, thank you for that question. I think there's a couple things. I think the good news is, I think we've staunched the closure problem that Texas was having of rural hospitals. We had a lot of communities that had lost their hospitals. In the short term, that seems to have stabilized. I would say that even the critical access hospitals that work with very small communities, we cannot put a hospital in every community anymore. That is just not realistic. And that's unfortunate, because that used to be the model. So we have to get creative about whether we're going to do something with what we call swing beds that can be long-term care beds or acute care beds. There's a lot of great work being done by our federally qualified health centers. So that's one place that I would definitely recommend. If you don't have a hospital, there's a good chance you have a federally qualified health center. The FQHCs are getting into some services that they haven't traditionally done. One of the discussions we've been having is, can they help monitor patients post-hospital discharge? One of the highest risk areas in healthcare is post-discharge to a readmission. You send somebody home, nobody's watching them, they don't follow the instructions, they don't do well, they end up back in the hospital. Our FQHCs are really looking hard at helping shoulder the burden of monitoring those folks at home, which would traditionally be the hospital's job. If we can be successful with that, I think we can keep people healthier. So I hate to use the word walls when I'm talking virtual stuff, but the boundaries between ambulatory and acute care are merging. They're not going to vanish. Not going to vanish. I'm not saying FQHCs are hospitals. However, there's a lot of service interplay there that didn't exist even 5 years ago. So depending on where you're thinking of, I may be able to connect you directly with some folks that could help. But I definitely think that non-traditional players that we don't think of as being involved in some of this acute care stuff are now at the table and in the conversation in a way they haven't been before. And that's going to be really good for small communities, because a small community is not necessarily going to be able to support a hospital the way it has historically. It's not without its challenges. I certainly don't have any illusions that the situation is super, super rosy, but I do think also schools and libraries as places where healthcare can happen is something we're seeing now that we have not seen historically, that I'm very excited about. We have to take care to where people are instead of having them come to the care. So you can't set up an acute care bed in a library, but if you had some primary care telemedicine there, maybe you're catching some people a little earlier so they don't have to go to the hospital. That's sort of the investment mindset that I would encourage folks to have.
And that was, like I said, that was from Catherine. She said that that she's actually in Red River County where they had lost their hospital. So
yeah, that's a tough
timely.
one. And again, I'm happy to talk. I work very closely with Torch, with the rural hospitals and others, but I'm certainly available to anybody who wants to have one-on-one chats. The loss of a hospital really hurts a community. And I think that John Henderson and the team at Torch are doing some really creative thinking around what else can be done. We talk all the time, but I am available, so folks can feel free to give me a shout. I'm happy to visit.
Nora, as I was thinking through this, and with the mission that Connected Nation Texas has in our communities, one of the things that I think so often is hard to grasp is hospitals and healthcare in general seem to be a silo in a community, just like education can be a silo, or and so how might a local leader be able to encourage, be engaged with this conversation at a local level? Like what would your advice be for somebody that's not in healthcare but sees this need, and has some local leadership that they can apply there?
What a great question, Wes. I used to work for the State Office of Rural Health, and every quarter I had to go to a rural community and talk to the hospital, the physician locally, the nursing home, and the Dairy Queen. And it was required as part of my job to walk around the Dairy Queen and strike up conversations with folks about how they felt about the healthcare in their community. If I were a rural local leader, I would be talking to the hospital, the school, the library, the other resources about what do we have? What can be multi-purpose? Where are people seeking care? Where are our gaps? People will tell you where the gaps are. If you ask the question, you might not be able to get them to stop telling you where the gaps are, but you really have to have that individualized interface with the people in that community, because sometimes there is a talk about a perceived gap may not be a real gap, because they may not know that there's a service that's available over here at the FQHC that is actually something their constituents can use. So I think it really starts with sort of asking questions. I would definitely, if I'm a local leader and I've got good relationships, go to the Dairy Queen. And I'm not being sarcastic about that. I got roots in rural Texas. The people of the Dairy Queen, they know everything. Those people don't miss a trick, or whatever your equivalent of your community is for the Dairy Queen. I find that talking to people about their perception of the healthcare in their community is the best way to start. Then you have to go to your facilities and figure out if the perception matches the reality. And you build your plan out from there.
Yep. Very good. I appreciate that. That's, it's just, we often are working with so many different people that are in local leadership, but they're outside of that medical or healthcare silo. And so, having that advice of how can you impact this? And I think we're all honest. Sometimes when somebody who's outside of our silo comes in to talk about something, we can be a little bit territorial, unfortunately. And especially if they're, trying to improve or enhance what we're doing. And so I think that's sometimes a weighty kind of situation to be in. And that's good advice. So I noticed Pam Wagner, another one of our BSMs in Texas. She made mention that we talk about mobile telehealth clinics sometimes. Thoughts on mobile telehealth and how that can be implemented? Things the good things, the bad things. What should we be looking for?
Absolutely. There's some good experiments being done right now with self-sufficient kiosks where I think it's running in Milam County, where you go in and there's a blood pressure cuff and there's all sorts of things. And it's relatively easy for the patient or someone to help the patient to have that interaction. Specialty care is a huge problem. It's the big city, right? You have to leave a rural community and go to the big city to get specialty care. The University of Texas system is actually building a virtual telehealth network to provide their specialists to any community in the state of Texas. And it's being run by my colleague, Mary Robinson, and it holds enormous promise. Because if you think about cancer care, for example, driving to MD Anderson is a burden if you don't live in Houston. Frankly, driving to MD Anderson can be a burden if you live in Houston, if you've been in the traffic in Houston. So we really have to think about expanding specialty access that way. And then also this behind on well care thing, if you want to talk about what's keeping me up at night, it is all the unmet need that is dammed up behind the pandemic. At some point, that wall is going to collapse. And we are all going to have to figure out how to not just meet the short-term need of the people who haven't gotten their well checks and things for the last 2 years, but also how do we move to more of a preventative mentality to get people, like in broadband, we talk a lot about the last mile, right? Everybody on this call probably knows that phrase, knows that conversation. Telemedicine, telehealth, remote patient monitoring can help close the last mile between the doctor and the patient, because we just don't want to be in that world where you go to the doctor, you get a prescription, the doctor says, eat better, exercise better, stop eating Cheetos and drinking Dr. Pepper quite so much, come back and see me in 6 months. If we're lucky, they take the prescription and they comply. They don't always. They may or may not choose to exercise, and then they come back to the doctor 6 months older and not any better. And so there's a balance there, I think, with privacy and with what people are comfortable with that has to be walked through. But if we can really use these technologies, the providers that do this, particularly the ones that were into it before the pandemic, tell me that it actually brings them closer to their patients if it's managed properly. We do not want patients calling doctors at 2 a.m. unless it's necessary, but a more regular cadence and conversation with your provider, plus information flowing back and forth, can hopefully get to some of that care stuff, because right now we are in not a great situation, and that bill has not completely come due, and it is something that gives me some anxiety, but also gives me another problem to solve. So it's a conversation that we're happening in my world all the time, and I really appreciate you pointing that there's going to be a bill, and it's not going to be pretty when it comes. We've all got to be ready.
Yeah, Nora, real quick before we I guess close up here, I had seen earlier this week, I think last week is when it actually came out, but I think the University of Arkansas had done a pilot program actually with rural residents in Alaska, and it doesn't sound like we're getting anything in Texas, but the reality of it is what they found was essentially what it was with hearing in children in rural Alaska, that almost 70% of those children were actually receiving some sort of post-care when they were identified as having some sort of hearing need. Whereas prior to that, I think it was 30% would have. And so I bring all that only up to say that not only will telehealth, telemedicine help close this gap in what's happening with closures or just the disparity in services, but it will also likely enhance healthcare services in rural areas as well, which is exactly what that study was really showing, is that not only were these students receiving the care that they needed, or these children were receiving the care they needed, but it was a 40% increase, percentage point increase over what they would have done prior to that, which is an enormous increase. And so, what are your thoughts as far as what the I guess what the enhancement and advancement in healthcare services will be maybe over the next decade or so for rural areas around the country?
I think the first thing is that every touch to the system provides an opportunity to catch something that might be wrong. So first of all, to your example, we should be catching that earlier, but those kids are probably not having a lot of contact with the system where there's somebody who could actually do the evaluation, figure out what's wrong, and get them into care. So the more regular the cadence of the interaction, be it in person or virtual, the better the odds that we catch something early and we address it early so it doesn't end up being a cost later. And Arkansas is a really rural state, and their university has done some groundbreaking work on rural pediatrics, really focusing on kids That was the inspiration for our rural pediatric model that I talked about. Alaska is a tough place. I can't imagine that there's 1,000 pediatric audiologists sitting around in Alaska waiting for patients to show up at their front door. So you're increasing touches to the system and you're increasing your access to expertise. So I am hopeful that what we can get to is a place where people will say, hey, Jane, while you're in here for your appointment, I noticed this thing and I can't handle this thing because I'm your primary care doctor. But you know what? We're going to take you over here for a virtual visit with the #1 doctor in the country about this that happens to be at UT Southwestern. We don't have that kind of access for our rural populations right now. You've got to drive to the big city, and that alone is a barrier that sometimes is really hard to get across, and then people don't get the care they need. Or one of my favorite sites of service is the school. The more and more we can grow school-based care, that's better for the child. We get an earlier intervention. It's better for mom and dad. They don't have to miss work. Earlier touches to the system. In fact, I'll close with this, and it's kind of funny to refer to the French, but the French have some of the best primary care outcomes in the European Union. And I asked a European colleague once, like, what's up with that? And they said, oh, the French are hypochondriacs. The second they get a sniffle, they run to the doctor, which is sort of the opposite of the United States. We tend to be, pull yourself up by your bootstraps, tough it out. I'm hoping one of the things that comes out of the pandemic is people stop coming to work sick, because no, if you're sick, unless it's absolutely necessary, please stay home and don't get your colleagues sick. Hopefully we've turned some of those corners. But when you look at these examples in countries that have different primary care, not just models, but mentalities, their outcomes are better because they're catching things earlier. And that's my hope, that we can kind of get into this last mile solution focused way of getting to people sooner, so that we can keep them out of more expensive settings of care. And we do not have to be French to do that. We can do that as Texans. We can do that as Americans. And we can do it our way and have control over how that happens. But if we don't do it, every encounter that's missed has a cost later in the system. And that's the part that I really want people to take away from this. Yes, we're asking people to do more up front, maybe build more up front, bring in a mobile clinic, build in a mobile van, build these connections. But every delay in care ends up costing not just the system, but frequently the taxpayer. So this is really something that makes good fiscal sense on top of everything else.
Nora, we are incredibly grateful for your knowledge and wisdom and what you shared with us today. I want to thank everybody that joined us. Jennifer, I checked with her just a second ago. She said she's in a really noisy environment, and she wants to reiterate that idea that we're just very grateful for your time. It has been a whirlwind of information for me, at least, over the past 30, 45 minutes here. And again, just extremely thankful for you taking the time to join us.
First of all, thank you for having me, and thank you, Jennifer, for only rubbing it in a little that you're not in Texas right now and you're someplace cooler. I am a rural Texan. My family is from rural Parker County, Texas. So this matters to me a great deal, that we do this well and we do it right. And I also forgot to mention that my dad was a fiber optics engineer. So broadband is something that's very near and dear to my heart. This whole conversation is something personally important to me as well as professionally. So I look forward to continued partnership with Connected Nation. I'm available. You all can reach out to me through Wes and Jennifer if you need something. And I look forward to future conversations. They will be important, because the work that all of us are doing has never been more important. And I'm just so happy to have partners like y'all to work with on it.